And we're back with Marc Surdyka. Welcome back, Marc. How you doing?
I'm doing well, man. How you doing?
I'm great. Do you want to talk about what you're wearing, or is this going to be just only
We're in a
video?
so I mentored this morning, as I've mentioned previously. I mentor orthopedic physical therapy residents occasionally. So I mentored this morning. It is December 21st, last day of mentoring before Christmas. I celebrate Christmas. So I wore an ugly Christmas sweater. I asked her to as well. So we are the only two wearing them this morning, but everybody loved it. And yeah, so I'm still just wearing it right now. And I asked you to wear one, but apparently you don't have one.
Yeah, I don't have one. I should though, but I don't. Maybe next year. Any other updates since we chatted last?
I don't think so. Heading to New Jersey for the holidays, flying out on Christmas Eve. That is where Nicole's family lives. So we'll be spending Christmas there. How about you? Are you going back to
Going back to
Tejas?
Austin. Yeah, I leave tomorrow, the 22nd. So I don't know what would be more chaotic. I feel like the 22nd is going to be worse total airport than the 24th for you.
Yeah, I'm never too worried about airport chaos. I'm more concerned about the weather.
Hmm.
It's been a little bit rainy here in LA, and then I think it's supposed to be rainy in New Jersey too. So just crossing my fingers that there's no flight delays or anything like that.
Yeah. Well, fingers crossed. Last year was chaotic with all the canceled flights in the Northwest. Actually, I feel like it was throughout the US. So it doesn't seem like it's going to be the case this year, but we'll find out. Let's rock and roll. The topic for today is all things shoulder impingement. Marc, let's start out with what typically, when people hear shoulder impingement or when it's commonly described, what do they think of, or how do people typically describe it?
Yeah, so let's start by describing the basic anatomy of shoulder impingement. So typically there are two categories of impingement: external impingement and internal impingement. Internal impingement is described as, and this is from a 2006 JOSPT article, impingement of the supraspinatus and occasionally the infraspinatus between the greater tuberosity and or the posterior aspect of the humeral head with the posterior superior glenoid labrum. While it is believed that contact between the humeral head and the posterior superior glenoid labrum is a normal physiologic occurrence, the biomechanics of the throwing motion are believed to intensify this contact and its effect on the involved anatomical structure. So essentially, what that is saying is they're describing one of two rotator cuff muscles impinging on the back of the shoulder, kind of between the ball and the socket during the extremes of shoulder abduction and external rotation, like seen during throwing. That's typically how internal impingement is described. External impingement is what we're discussing today and what most online discussions are referring to. And so we just call it shoulder impingement or subacromial impingement. And this type of impingement is further broken down into primary impingement and secondary impingement. And the way that it was taught to me to simplify the two was to think about primary impingement as more of a degenerative process whereby the subacromial space decreases. So this might occur in slightly older individuals. On the other hand, secondary impingement was more common in younger individuals and overhead athletes because it had more to do with your scapulohumeral rhythm, rotator cuff activation, and those kinds of things. And there are different variations of this, but for our purposes and just for people's knowledge in general, it honestly doesn't really matter. So, what is subacromial impingement or shoulder impingement? So, there's a nice 2003 review paper by Lori Mishner, who we've had on the podcast twice now, Philip McClure, and Andrew Carduna, titled Anatomical and Biomechanical Mechanisms of Subacromial Impingement Syndrome. And in it, they write, the subacromial space is defined by the humeral head inferiorly the anterior edge and undersurface of the anterior third of the acromion, coracoacromial ligament, and the acromioclavicular joint superiorly. If you need a visual, assuming you're not driving or something, I suggest Googling it or watching our YouTube video. But if you put your fingers like on the edge of your shoulder on top of a bony prominence, just underneath that is the subacromial space. You're thinking about the space under the acromion, subacromial. And then the authors go on to state the tissues that occupy the subacromial space are the supraspinatus tendon, subacromial bursa, long head of the biceps brachii tendon, and the capsule of the shoulder joint. Any or all of these structures may be affected with subacromial impingement syndrome. So sometimes the word syndrome gets attached on the end there. So you're thinking about one or all of these tissues being compressed in that subacromial space. Most people are going to bring up the supraspinatus tendon, one of those rotator cuff muscles, when describing the different supposed negative effects of impingement. So let's start there. Any questions before moving on from that?
No, that was a lot of different types of impingement, but that helps as a good background.
Yeah, like I said, I think most discussions when you're watching YouTube videos or, like I said, the potential negative effects of impingement or the diagnosis, it's talking just about that subacromial impingement and like the discussion that we're having today. And later on, we're going to talk about upright rows. So people are talking about that kind of impingement as it relates to upright rows. Did you learn all that different stuff in school or no?
Not that to that nitty-gritty differentiation. They kind of used it as one entire term, impingement. What about you?
I don't recall.
Yeah.
Some of that might have been like what I learned in residency, but yeah, I don't recall school or residency. So, okay. So moving on from that, the popularization of the shoulder impingement theory can be attributed to Dr. Charles Neer, who was a shoulder surgeon. So he had two seminal papers, one in 1972 and one in 1983, but he had been performing surgeries for this since 1965. And his hypothesis was based on what he had been seeing during surgery and what he observed when dissecting cadavers. In his 1983 paper, he wrote that he believed 95% of tears of the rotator cuff are caused by impingement. So there was no clinical trial that occurred, right? He did surgeries, he did these dissections. This was his hypothesis. And so he goes on to describe three progressive stages, his rationale, testing for impingement. So maybe in school you learned like, the Neer's test for testing the shoulder. But essentially he proposed and developed a surgery to treat the shoulder impingement. And there were other surgeries occurring, but he really developed this one. And so the acromioplasty, now more commonly referred to as subacromial decompression, involves removal of the subacromial bursa, cutting of the coracoacromial ligament, and shaving of the acromion. And the intention of the surgery is to decrease the compression of tissues within the subacromial space, such as the supraspinatus tendon, during various shoulder movements to reduce symptoms, right? So if we're removing any of that tissue that's occupying that subacromial space, then hopefully we're decreasing this compression and impingement. And although this sounds reasonable, there was no concrete evidence to substantiate the shoulder impingement theory or the benefit of surgery. But obviously Neer's ideas have influenced medicine, rehab, resistance training over the past 50 years, pretty significantly.
Did you ever use the Nears impingement test in practice when you were a new grad?
No.
I don't even remember what it is. Don't you hold the do you hold the scapula as the arm comes up?
Yeah, you can hold it and like you elevate the shoulder like with your thumb up, right? With like more external rotation, and then you can do it like with the thumb down, and then you're trying to decrease the motion of the scapula so that theoretically you're recreating impingement of tissues in the subacromial space.
To the subacromial decompression, it's still utilized today. It seems potentially less so or less well thought of. Does it actually fix shoulder impingement, or what's the data on subacromial decompression as a surgery?
Yeah, so we're going to talk about the effectiveness of the surgery. Before doing so, some might argue that the idea of the surgery itself is flawed. So there's actually a great paper by Jeremy Lewis in 2011. So what we're describing, challenging this diagnosis and its benefit in practice is not new. 2011, this paper's 12 years old, and the paper is titled Subacromial Impingement Syndrome, a Musculoskeletal Condition or a Clinical Illusion. And in it, he challenges the rationale for subacromial decompression in the first place. So one argument is regarding the area of pathology. When people think of impingement, they think of the upper or superior portion of the supraspinatus rubbing up against the acromion and becoming frayed, but it's often the underside of the supraspinatus that shows changes. Another argument is regarding acromial shape, and this was a big part of Near's theory. If going back and reading those papers, 3 shapes of acromion are typically described: flat, curved, and hooked, with hooked being the most problematic because it occupies more of that subacromial space, but the data for that also isn't too convincing. And then shortly, we'll talk about the concept of shoulder impingement with regards to movement and some of the issues there. But going back to the surgery, subacromial decompression, and you mentioned, maybe we're not seeing it as much. I don't know what the data is today in 2013. There is a paper from 2014 that found that there was a 746% increase in the surgery from 2000 and 2001 to 2009 and 2010. So 746% increase in less than 10 years. And you would think that we have this, huge breadth of literature supporting the surgery, which we're going to get into. But it just kind of shows, how we take an idea and run with it and figure out if it works after the fact when the dust starts to settle. So to my knowledge, these are the papers most relevant to the discussion in chronological order. So there's Kolk et al. In 2017 from the Journal of Shoulder and Elbow Surgery. They performed a double-blinded, randomized clinical trial with 9 to 14 years follow-up. And what they did was compared bursectomy, so just removal of the bursa, to bursectomy plus acromioplasty, so more of that traditional subacromial decompression. And the authors found that the addition of the acromioplasty did not result in a clinically relevant improvement in shoulder function or relief of pain at 12 years follow-up compared with bursectomy alone. So like shaving that acromion and cleaning up some of that other stuff didn't have any additional effect to just the bursectomy alone. They also did not find a statistically significant difference in the prevalence of rotator cuff tears after 12 years. So even shaving down that acromion didn't affect rotator cuff pathology. So that was Kolk in 2017. Beard et al. In 2018 from The Lancet conducted a randomized placebo-controlled trial to determine whether decompression compared with placebo, which was just arthroscopy only, improved pain and function, whether decompression differed in outcome to no treatment, and then whether placebo differed to no treatment. So 3 groups there. And this is known as the seesaw trial. That's how it's often described. So CSAW, which just stands for Can Shoulder Arthroscopy Work? If you never knew what seesaw stood for. And so there were 3 big takeaways from this study, and these are direct quotes. 1, there were no differences in outcomes between decompression surgery and placebo surgery. 2, surgery might not provide clinically significant benefit over no treatment. And then 3, the mechanism of the treatment effect in the patients who received surgery might be the result of a placebo, postoperative physiotherapy, or other factors. And, now when we refer to placebo, we're often referring to these different contextual factors associated with any treatment, whether it's surgery, exercise, hands-on care, etc. Following that, 2019 Cochrane Review. Cochrane Review's often considered like the gold standard for appraising research. That review concluded that high certainty evidence shows that subacromial decompression does not provide clinically important benefits over placebo in pain, function, or health-related quality of life. Same year, British Medical Journal created a clinical practice guideline that made a strong recommendation against surgery. So usually it's like a big panel of individuals, and I'm pretty certain that they try to include, at least one patient, in these panels when making these recommendations. And they write, the panel concluded that almost all informed patients would choose to avoid surgery because there is no benefit, but there are harms, and it is burdensome. And then another systematic review, meta-analysis by Ladoja in 2020 in the British Journal of Sports Medicine concluded that subacromial decompression surgery provided no important benefit compared with placebo surgery or exercise therapy and probably carries a small risk of serious harms. And then lastly, Pavola et al. In 2021, also in the British Journal of Sports Medicine, conducted a randomized, double-blind, placebo-surgery controlled trial to assess the long-term efficacy of arthroscopic subacromial decompression. They also included an exercise group for comparison, and the authors concluded that arthroscopic subacromial decompression provided no benefit over diagnostic arthroscopy, or like their placebo group, or exercise therapy at 5 years for patients with shoulder impingement syndrome. And I'm mentioning the journals because they're all well-respected affiliations. They're not random articles in predatory journals. So to answer your question about like fixing it, or like does subacromial decompression, quote unquote, work? Not better, from these studies and these reviews, not better than placebo or exercise or no treatment, and probably not for the reasons we previously believed. And as I mentioned, the surgery also doesn't seem to change the long-term prevalence of rotator cuff tears. So that also kind of questions the initial theory of this impingement and fraying and damage to the rotator cuff tendon, the supraspinatus.
Does impingement actually occur then?
Yeah, this is a good question, and I think one that people may have, maybe it's a straw man to say, like I say that impingement doesn't occur. It does occur. Impingement does occur, but it's not the boogeyman that we've made it out to be. I think if you want a broad overview of this specific biomechanical literature, you should start at a 2020 paper by Rebecca Lawrence, Jonathan Brahman, and Paula Ludwig titled Shoulder Kinematics Impact Subacromial Proximities, a review of the literature. And for me, 2 big highlights. One, contact between the supraspinatus tendon and coracoacromial arch is common with just a regular reaching task. And there's no difference between symptomatic and asymptomatic individuals. So a lot of us are probably, quote unquote, impinging all day long without even realizing it. The other thing is that we often think about this painful arc between 70 and 120 degrees of shoulder abduction. So just kind of lifting your arm out to the side around shoulder height, maybe a little bit higher. But oftentimes, this impingement is occurring below 70 degrees. And actually, by 90 degrees, the rotator cuff is positioned in such a way that it no longer can be compressed or abraded. And that review has some nice images to show how that might work, like where that footprint of the supraspinatus tendon is relative to, the humerus and the acromion. So those are nice kind of images to look at. And then those two pieces of information alone kind of dispute a lot of what is typically discussed as it relates to shoulder impingement. And someone might throw out a comment about internal rotation. But actually, and it's in the same review, the research there is pretty unclear, inconsistent. And some research suggests that internal rotation has no effect or increases the acromiohumeral distance. And then there's like some other recent papers related to the acromiohumeral distance, which is just the distance between the humeral head and the acromion, so the space under the acromion, that shows that acromiohumeral distance is not related to shoulder pain and may even be larger in those with shoulder pain.
Why then do people describe, or what is that sensation of tightness or pinching overhead? If you were to describe that to a patient that fortunately, these structures are getting closer below this 90-degree range, what if they ask, well, then why is it hard to get above head? Or why is there that kind of impingement sensation? What are the other potential reasons as to why that occurs, or that sensation of either pinchiness or lack of range of motion?
Yeah, so range of motion is a whole beast. There's a whole host of reasons why someone might be lacking range of motion. And in terms of the pinching sensation, once again, it's not to say that structures can't be compressed. And what I just suggested was in reference to the supraspinatus. I'm not as clear as it relates to some of the other subacromial structures. So it's very plausible that some structures are being compressed. But once again, if this occurs in asymptomatic individuals just as often, if it occurs when you're raising your arm to shoulder height in everyday activities, it's just not something that we have to really vilify and make people concerned about. And that's what we're going to get into, because then you think, well, if I'm pinching structures every time I raise my arm, that means I'm damaging them. It's going to make it worse. I need to stop lifting my arm overhead. And that's something that we do see, is that people hear your tendon is being pinched. It's you're tearing your rotator cuff, whatever it may be. I'm going to stop raising my arm overhead. And then what that actually leads to is reduced range of motion, deconditioning, fear avoidance, catastrophizing. Does that answer your question?
That does. Yes. So you've already started this new discussion, but to the views as to currently what patients think shoulder impingement is, or the impingement itself, has there been a better definition, or not a definition, a better terminology that either in the literature is utilized or that we as clinicians can use when describing this to patients?
Yeah. And just one more clarifying piece of information is that I don't know if I have a straight answer for every sensation that a patient describes, whether this is the shoulder or elsewhere. And I think sometimes we do a disservice by trying to give a very specific anatomical reason or structure. And in most cases, it might not play a huge role in the overall management and plan of care. And that's something that we're going to talk about a little bit later. So have we come up with better terminology instead of shoulder impingement? Yes and no. This is what I wrote in our blog. And so I'm just going to read this and then we can talk about it some more. But different terminologies have been proposed, such as subacromial pain syndrome and rotator cuff related shoulder pain. And to me, the more important question is, what's the purpose of a diagnosis? And hopefully, at least in part, it's to inform management. Do these diagnoses do that? They do to some extent because, as you know, surgery isn't recommended. However, shoulder impingement and these other labels attempting to fill its void have become catch-all diagnoses for any non-traumatic shoulder pain that isn't related to instability, frozen shoulder, and some other diagnoses that may respond to specific medical management. And sometimes we've talked about this, and Lori's talked about this, these different buckets of like, a stiff shoulder, which might be frozen shoulder, or, osteoarthritis, or this unstable shoulder, or, some of these other categories. So basically we're saying that this shoulder pain doesn't fit some of those other categories because maybe they would benefit from specific medical management. So they're an attempt to simplify the complex and multifactorial nature of pain while also easing our own uncertainty about the exact tissue structure that may be contributing to symptoms. We're so eager to label a specific structure when someone is experiencing pain. But, as a physical therapist, as long as I know you're experiencing non-traumatic shoulder pain unrelated to some of these other diagnoses I just mentioned, how we name your pain doesn't necessarily influence rehab. And that might be hearsay for some, but what's more useful for me is knowing your age, occupation, lifestyle, sleep habits, exercise habits, goals, what makes your symptoms better, what makes your symptoms worse, etc. You might have the exact same diagnosis as someone else, but your answers to these questions could be vastly different, and those answers are what influence rehab. So this doesn't mean that the general rehab process needs to be significantly different from what's already being used. Whether you use the diagnosis of shoulder impingement, subacromial pain syndrome, rotator cuff related shoulder pain, it's the explanation that changes and matters. So, hey, if we know that the shoulder impingement is normal, then exercise is safe and encouraged. You're not damaging your rotator cuff when you lift your arm and experience pain. You don't have to worry about removing a piece of bone to get better. And then compression of tissues is normal. In the shoulder and elsewhere, we compress nerves, tendons, ligaments, and muscles all day long when we sit, bend, lift, twist, walk, etc. And part of the reason the diagnosis matters and the terminology matters to some extent is there's two good studies about this topic, and probably many more, but two that I'll refer to. One is by Zadro et al. In 2021, and they found that participants labeled with subacromial impingement expressed feelings of psychological distress, uncertainty, and that the condition is serious and has a poor prognosis. And hearing that makes sense when you think about this paper from Cuff and Littlewood in 2018 that explored the beliefs, experiences, and perspectives of patients diagnosed with shoulder impingement. And so these are direct quotes from one paper, right? Because it's like a qualitative paper. So the patient said, "It is the tendon being caught by this piece of bone and wearing it away. How are we going to get this pain to go away? By removing this piece of bone. I can't imagine how any amount of physio is going to shift this piece of bone, which is in my shoulder." And then another patient said, "I couldn't see how physiotherapy would help with the tear. I'd be worried that I was doing even more damage." And then the author suggests that the diagnosis can negatively influence expectations, which we know are important for recovery and may act as a barrier for rehab. So if you give somebody this diagnosis of shoulder impingement, you describe these tissues being compressed, your supraspinatus is being frayed, and it's because of your hook-shaped acromion, then yeah, why would they think that any amount of rehab would help, they might automatically assume I need to go to the doctor and get that shaved down. And if my muscle is torn, how does adding more load and more exertion, how's that going to, like, wouldn't that make that more torn? And hopefully people understand that patients and clients are not getting all of their medical information from direct visits with their healthcare providers. So if you say you have shoulder impingement, you might even do a really good job of trying to be nuanced. You still have to be careful with some of these descriptions because that patient might go home and Google it or go on YouTube, and then they go down this rabbit hole where someone is showing a skeletal model of your supraspinatus just being crushed. And now they think, well, I just wasted $60 at physio, and instead I should have been going to, an orthopedic surgeon. So have we found better terminology? Maybe, compared to shoulder impingement, because of some of those negative connotations associated with that diagnosis. Is that terminology perfect? No, I don't think so.
And you could make that same argument or have the same discussion around osteoarthritis and people's views on bone and a lot of these other diagnoses. And I believe I've heard Eric Mehta, who we've had on multiple times, talk about he's open to the terminology or the name shoulder impingement syndrome because he will explain it to patients as a syndrome is just a collection of findings. This doesn't mean it's inherently bad. This is just what we're seeing. And it's, again, like kind of pulling someone back from their prior beliefs and saying what it may or may not mean. But like you said, regardless of the information we provide and the expectations we set for what it may or may not mean, there's so many other areas of information and people and outlets that they're getting that information from. It's incredibly tough to like change the direction of that ship of what their thoughts are of that term or what it's doing inside of their body.
Being a physio is hard, man. Like, because we're describing this in a perfect scenario where maybe you have an hour with the patient. People listening might have 30 minutes, 20 minutes, 15 minutes. And so, yeah, we do our best to provide that nuanced perspective. And even sometimes that's not enough. And so, like, for anybody listening, hopefully you're understanding that we're not trying to place blame or fault. Like, we understand the difficulties of being a physio and different environments and scenarios. This is just something to think about. And kind of what you described with Eric and everything else, like that's true of any diagnosis, right? Like, hey, yeah, like your disc herniation might be contributing to the symptoms that you're feeling down the back of your leg, or hey, your osteoarthritis might be, like, it's fine. And then, we try to just add a little bit of these caveats or nuances to some of those labels or discussions if needed.
Yeah, and again, you could use the same argument for like FAI, femoral acetabular impingement, or FAI syndrome, and describing it very similarly. So moving beyond this, staying with the shoulder and shoulder impingement, there are commonly exercises and movements that are thought of as bad because of this idea that the shoulder is being impinged or more damage is occurring and all the things you mentioned previously. Let's start out with a big question. Mark, are there actually bad exercises?
As you know, I'm not a fan of these dichotomies. There are better or worse exercises depending on a person's goal, symptoms, function, etc. But in general, I don't think it's helpful to describe exercises as good or bad.
An exercise that is thought of or commonly viewed as bad or dangerous as it relates to the shoulder is an upright row or our upright rows. One, maybe describe why these are thought of as or explained as inherently bad for the shoulders or dangerous or going to lead to XYZ. What are people saying in the social media world, or what you've heard patients say, and then let's describe maybe why those things aren't the case.
Yeah, and it's always interesting too when you hear exercises labeled as bad, because I want to know when they become bad. So if you do an upright row, if you were just to bring your arms up into that position with no weight, is that bad? Is it bad when you add 1 pound? Is it bad when you add 2 pounds? Is it bad when you go to from 89 degrees to 91 degrees? So there's so many factors that go into this that where's that threshold where it goes from good to bad, or is it always bad? It doesn't matter. Like, you raise your hand only up to your belly button, and just because it looks like the upright row, it's bad. But, I think common reasons why people think upright rows are bad for your shoulders. Obviously, there's this traditional impingement theory. I think there's prominent YouTubers who talk about it and perpetuate it. And it's really easy to take a skeletal model and smash the supraspinatus with certain arm movements. But as I discussed, based on this biomechanical research, that's not really how it works. So just taking a skeletal model and, manipulating the shoulder and the arm and the associated muscles maybe attached to that model really isn't that helpful if you're moving it in ways that aren't physiological or normal. And I think it's still taught in schools and medical practice and discussed in a lot of research. People have cited a 2011 article in the Strength and Conditioning Journal as a counter argument about why upright rows are actually bad, especially when they're performed to 90 degrees. But honestly, that article is more of an opinion piece with nothing that really refutes anything that is being said here. And to my knowledge, there's no research associated with the upright row being harmful. And there are going to be anecdotes where someone says, hey, I did an upright row and it hurt my shoulder. But on the flip side of that, there's plenty of people. And when I say plenty, you can go, read just as many YouTube comments. People say, well, I did upright rows and my shoulder felt great. I'm not putting too much stock into either one, but I'm just saying, if you're going to take one anecdote, you have to consider that there's going to be anecdotes on the other side of that coin as well.
And you created a video on the upright row specifically, and you did the upright row for 30 days. Do you want to explain why you did that and maybe the messaging you were trying to get across with that?
I regret it. So I did upright rows for 30 days. I did Jefferson curls for 30 days. And why did I do those videos? Honestly, I thought it would increase the views and exposure of the video. And it actually kind of backfired because people use it against me. Because I've seen other videos. People go like, I walked for 30 days or I ran a 5K for 30 days. And they're kind of like inspirational and like they get healthier, they feel better, or like they develop this really good habit. And I was like, oh, like I can do something similar. And one, it's kind of a pain in the ass to film every single day. Like, I don't really film my workouts all that much. So to do that was a pain in the ass. But like I said, it kind of backfired because there were different comments. So someone might say, well, you didn't do them correctly or in the way that would injure your shoulders. So my entire argument was negated because of how I showed myself doing the upright rows. Or someone said, you're too small and didn't lift enough weight. So because of my muscularity and the amount of weight that I lifted, that negates any of the information that I presented. Or someone said, great, you did them for 30 days. Try doing them for 30 years. And I don't remember if this was this video or the Jefferson curl video, but someone compared it to smoking for 30 days. And this thing got like tons of thumbs up likes. And the comparison was that smoking for 30 days is not going to present itself, in any negative way that quickly. But if you were to smoke for 30 years, you'll have problems. And so that was the comparison to upright rows. Like, of course you didn't have issues after 30 days, but imagine you did them for 30 years. You're going to have significant issues with your shoulder. So after those two videos, I decided no more 30-day videos for me. They're a lot of work. And like I said, didn't really seem to add any value and actually just kind of backfired.
And to that smoking point, maybe the concern about that comparison is there's an unreal amount of evidence on the extreme negative effects of smoking, and that is not present for pretty much any type of exercise.
Yeah, but people are going to try to find one point that they disagree with, and it may or may not be valid. And if their point is valid, either way they use it to dismiss everything else in the video if they can find one thing that they disagree with. So it can be challenging. Like I said, like trying to disseminate what we describe as evidence-based information or evidence-informed information. And I got asked this on a podcast, like, well, how do you do that? And it's like, well, you know what? I'm reading the research and interpreting it the best way that I know how and presenting that way in hopefully a digestible format. And I'm going to get things wrong and things are going to change, but I'm doing so in the best way possible and trying to make it entertaining. And that's not always easy to do, obviously.
Going from here, if someone does want to incorporate, let's say, upright rows as an example, or really any new activity, like you're saying, it's not the inherent exercise itself that is quote unquote bad. It's how it's progressed, it's how it's introduced. What are the things that people should be concerned about or should focus on when adding in a new activity or exercise? What are the things that actually matter?
First of all, and I've made this joke before, I'm not getting paid by Big Upright Row. I don't care if you perform upright rows or any other exercise. It does not affect me in any other way. So we just have to understand that the upright row is not different from any other exercise. If someone has knee pain with squatting, we don't deem squatting bad or dangerous or ask that person to avoid squatting for the rest of their life. You could say that about walking. You could say that about reaching. Just because someone has pain with the movement in one scenario, we don't label it bad. But we do that with upright rows and other exercises that have been labeled as bad or dangerous or harmful. Instead, we should think about what are the variables that you can adjust: weight, range of motion, tempo, sets, reps, rest times, total volume, etc. So if somebody had knee pain with squatting and they came to you and they wanted to keep squatting, and let's say it's not just squatting to use the restroom or sit on the couch, but it's barbell back squatting, your first thought isn't, well, this is a bad exercise, let's get rid of it. It's, what modifications can we make? And then how do we build that back up over time? And in some cases, it is totally acceptable to swap out squatting for an alternative if it meets the person's goals and helps them get back to what they want to do. And the same could be said for the upright row. Maybe someone says, well, I'm doing it for my shoulders and my traps and whatever. And let's say every modification you try doesn't work. Well, hey, how tied are you to the upright row? How much do you care about it? I don't. I'm just doing it because I heard it's good for my shoulders. Okay, let's try another variation and see how that feels. I don't think it has to be that complicated.
I think the big thing is being just very agnostic about any exercise for good or bad and just viewing it as this is a movement that can be altered or progressed or whatever it is, people's, whether they have to be in that position for their job, whether for their sport, or they just enjoy it and want to get better at it. How do we modify for what they need to do versus what they want to do versus all these other things? There's so many variables and factors that we can consider and have these discussions on how can we change this or how can we keep it, or do you even want or need to do it? And if so, or if not, we can remove it or we can adjust. Any thoughts there?
Yeah, this isn't a moral discussion, right? And exercise isn't good or bad. And I think we tie so many emotions to some of these discussions. And, maybe you're a big fan of somebody who has claimed that upright rows are bad or dangerous. You can still be a fan of that person and like that person more than us. Disconnect that emotion and appreciation you have for them and just consider some of what we're talking about as it relates to upright rows. Because it's not an us versus them. It's just, we're just talking about a topic.
There are way more controversial and important topics than an upright row being good or bad. What else do you feel like, if anything, should we hit on or chat about?
Yeah, I think one other question that you had proposed is like, when symptoms do occur with a new activity or an exercise that was previously asymptomatic, what steps can people take to evaluate how to adjust training? I think it's simple here. It's just ask yourself what changed, if anything, right? It's possible that you perform upright rows and develop shoulder pain, but maybe it's because it's a new exercise challenging your shoulders in a range of motion and position they're not accustomed to, using a load that's more than you can tolerate. So the solution is probably just adjusting some of those variables I mentioned or choosing a different exercise. And you being the listener, you might be a trainer or a coach or a physical therapist and never program upright rows for your patients or clients. That is fine. There's plenty of exercises you will never program. You just don't have to vilify or create unnecessary fear around it as well. And a question that I've received is, well, if impingement isn't the primary problematic issue with upright rows, what is? And I think, as I said, impingement occurs, and it can be a contributing factor to symptoms in some cases. But we can also just consider overload of the tissues. Like upright rows, they do load the rotator cuff. And if it's, like I said, if it's a range of motion and a position and a weight that you're not accustomed to, it's certainly possible that it's aggravating. What's kind of interesting is that something like the on knee, like your elbow on knee external rotation, you know what I'm talking about? Like if you're sitting, you have your foot planted on the ground, your knee is bent, you have your same side elbow resting on your knee, you're holding like a dumbbell or a weight in your hand. Doing that exercise is labeled as like the best shoulder exercise. But if you think about it, you're taking a weight, your arm is positioned in some form of, flexion or abduction or, elevation. You're lowering yourself into internal rotation and actually trying to maximize internal rotation of the shoulder under load and then bringing it back up. And we label that as good and upright rows as bad.
And to add even more to that, the question that you kind of asked yourself and answered there, when symptoms do occur, there's also the option of, is it severe enough or large enough symptoms to warrant change? There can be a discussion with patients or clients or yourself of, I probably have a few options here. I can try another set with the same exact load and see if this changes. Does it get better or worse, the same? If it's the same, are these within kind of my tolerable limits? I'm okay with it. And kind of that discussion around, not everything has to be completely pain-free. And if there are symptoms, depending on the context, if it's within kind of your tolerable range, it may be okay and we can continue. And that may also provide some relief that I can do this exercise with some level of irritability. And as long as it's not interfering set to set or the next exercise, the next session, and I enjoy this, then you can continue with it. So there can also be that discussion of, these are the things we can manipulate, or we may not have to manipulate at all, even if you do have some level of symptoms.
Yeah. And obviously the rotator cuff tendons are different than some of these other tendons, but we see thickening of, let's say, the supraspinatus tendon, right? If we see thickening of the Achilles tendon or the patellar tendon, and like I said, these are different tendons, we think that, okay, maybe there was some form of overload, but also we might think this might be an adaptive process and maybe even a beneficial thing that's occurring to accommodate some of these changes that have happened in the Achilles tendon or in the patellar tendon. And that goes back to, potentially it is at least partially a load related issue. And that just simplifies our description too of, you know what, you painted all weekend long, maybe you just did a little bit too much. Let's let things calm down. And then next time when you paint, rather than painting for 8 hours, do it in 2-hour bouts or whatever. Like it's just really, it's creating the same plan that you would create for a patient without maybe creating this unnecessary worry about what's happening under the skin.
And for whatever reason, these want or should be introduced in someone's training or plan of care, and patients are hesitant. Maybe you're implementing it because it's for their job or their day-to-day. There can be simple daily tasks that you can say, you kind of get in this position throughout the day, like loading up your groceries onto your countertop or XYZ. That can also be a light bulb for patients to think, oh yeah, I do this every day. Just because I'm doing it with a barbell or a dumbbell, it's not really different. It's just a change in loading and volume. And how do I adjust that?
I think that's fair.
Any other final thoughts, Mark, before we call it here?
No, I think we have a YouTube video, really good visuals. I listed off a lot of research. I think almost all of that research that I mentioned is linked in the blog. Like I always say, you can check my sources to see how my interpretation of the research. So like, feel free to check all those. Those are there for you. But no, I think we covered most everything we wanted to talk about in a pretty decent time frame.
And I'll link some of our prior guests, like you mentioned, that elaborated on this topic and similar topics surrounding the shoulder special tests, shoulder impingement, so people can get a variety of other opinions from researchers and clinicians in addition to this specific episode.
Yeah, not like, it's crazy how long this podcast has been around now, and it's still, compared to some podcasts, in its infancy, but we've had so many great guests, and not just the shoulder, everything, but we have so many great podcast episodes that you can go back and listen to related to the shoulder.
All right, we'll call it there. Thanks again, Mark.
Thank you, Chris.